just put the microphone up, Nikki. It's my pleasure to introduce this session on medical adherence in paediatric epilepsy. So I will be introducing three speakers. We have Sophie Knight, the Head of Consulting at Health Innovation East. Health Innovation East is the NHS's innovation arm for the East of England, helping turn great ideas into real-world health and care solutions by connecting innovators, clinicians, researchers, and industry to improve patient outcomes and system efficiency. Also really pleased that Dr. Lisa Whiting can join us. Rosemary, as mentioned on the programme, is unfortunately unwell and unable to join us. Lisa has played an integral role in this project, very grateful for her help. Lisa was the Associate Dean for Research at the School of Health and Social Work at the University of Hertfordshire, and she was also the Acting Director of Research Culture for the university before retirement. The third speaker is actually me. So I'm going to remove my Chair of Open UK hat, and I'm standing here as the clinical lead for NHS England, East of England paediatric epilepsy team. And if we could have the slides, I will kick off with the first slide. Oh, I see. I just pressed the button. You would have thought there has been an opportunity for me to work that out at some point in the last 51 years. We'll just have a little look at the first slide. So in 2019, we were really fortunate to have Martin Kirkpatrick come and talk to us at this meeting about medicine adherence, and he likened this to the elephant in the room. And what Martin showed us was that we weren't alone in paediatric epilepsy with having problems with adherence. He showed that in chronic health conditions such as asthma, that only 2% of patients could be shown to be fully adherent to the treatment plan that had been provided to them and taking all the medication that they've been prescribed with. And he showed us data for both diabetes and asthma that showed very high levels of difficulties with medicine adherence. And on average, it was shown that about 70% of the medication that was prescribed for those long-term conditions was actually being taken. Then what he showed was the data that he and his team, which if I remember rightly, Colin, you were a member of that team, is that right? I seem to be in and out on the microphone a little bit, but I'll try and stay as still as possible, which is not my usual sort of... Yeah, that's not what I usually do. The data for children with epilepsy, what we found was that on average, about 69% of the medication that is prescribed was being taken. And about 25% of our patients were taking less than 50% of the medication that was prescribed. And only about 20 to 25% of our patients were taking more than 90% of our medication. So I think we have this view that just about everyone we see is going to be fairly close to taking all of the medication that we prescribe, but that really isn't the case. And I remember that Martin put a slide up citing, I think it was an American, it's completely escaped me now. But there was a famous quote about how medications only work if you take them. Martin sketched out the difficulties of impact on quality of care of problems with adherence to medication. Now, the purpose of getting Martin to come and speak to the Epilepsy12 Open UK Conference, of course, is to fertilise discussion so that we then change something, we improve care, that we change standards, and that we propose solutions and then enact them on a national basis. And I think the honest truth is that we sort of forgot a little bit about adherence. So not much has happened in national terms in the world of paediatric epilepsy, certainly not in terms of policy or guidance or standards or anything else, as far as I'm aware, since 2019. So it stands as an elephant in the room that is still there. So anyway, I'm here to talk about the elephant in the room, and wearing my hat as the NHS England, East of England clinical lead for paediatric epilepsy, we asked for some help. And so we went to Health Innovation East, and they kindly introduced us to the University of Hertfordshire, and we've done the piece of work that will be described to you today. And so what we want to do is freshen up that conversation, think about what solutions we can propose and how we could help with improving the care of children around this area of medication adherence. So, Sophie, I think you're up first, aren't you? Thank you very much.
Thanks, Richard. I'm Sophie Knight from Health Innovation East, and we were commissioned by NHS England, East of England, to scope a project around medication adherence in paediatric epilepsy. So this slide sets out the stages of the project and what we set out to do. We started with a rapid evidence review to understand what are the barriers to medication adherence in children with epilepsy, and what has the literature already identified as solutions to address them. We're not actually going to talk about that rapid evidence review or the results from that today, but it has been published, and there's a link that we'll share as well with these slides. We then realised that there wasn't much in the way of published literature around what children and young people and their families directly said, or direct consultation with them. So we commissioned the University of Hertfordshire, who's really experienced in consultation with children and young people, to do that work. And that's what Lisa is going to talk about in quite some detail. We then synthesised the results of the evidence review and the consultation. And we took a biodesign approach. So I'll briefly talk through what that is, but it's essentially trying to take a very needs-based approach. So rather than starting with solutions or starting with what might have already been tried by way of solution, it's about really trying to understand what the needs are and being at that point completely solution agnostic. So we did an interactive workshop, and I'll talk through that and what that looked like. And that led to us being able to put together an innovation horizon scan, which is something that we do regularly at Health Innovation East and that the National Health Innovation Network do, which is about essentially identifying innovations that are new and emerging, that are meeting identified needs. So we did that horizon scan. We identified innovations that could address the needs that had come out of the work we'd done, and then we developed case studies on some of those most promising innovations. And we've written all of that up. So again, I will talk through at the end one of those innovations that we identified and how that could move forward, and what the next steps might be for how we put all of this into practice. But for now, I'll hand over to Lisa, who will talk through the consultation work.
Good afternoon, everybody. Really lovely to be here. I think I'll have to put the microphone down again a bit. Thank you. So, as Richard said, I'm Lisa Whiting. I'm from the University of Hertfordshire and here in place of Rosemary. So our work focused on a qualitative study to do with medication adherence in children and young people. As we know, and has already been very well articulated today, adherence can be a problem for children and young people, not just with epilepsy, but other, obviously, illnesses as well. Previous work has told us, for example, there was a systematic review done by Yang et al. Back in 2018, that medication adherence for children and young people with epilepsy can be enhanced by things such as good healthcare practitioner support, socioeconomic status, and good family support. And we also know from other previously published work that a negative impact can be things like lack of parental support and also poor health literacy in parents. So whilst there has been some data around adherence and epilepsy medication in children and young people, that based in the UK has primarily been more survey data. So whilst really helpful and useful, there has been a lack of qualitative data where people have gone and asked children, young people, indeed parents themselves about their experiences of medication and their adherence to it. And so that's what we were commissioned to do by Health Innovation East, as Sophie has said. We were on a very tight time frame with this, so I would describe this as more exploratory work more than anything else. So by the time our contract was set up, we literally had about 4 or 5 months to get this data. So just to say that we had at the back of our mind this definition from NICE about what adherence means, and it being the extent to which people actually do match their actions to the agreed recommendations of the physician doctor who has prescribed it. So we had 3 key areas that we wanted to look at, that we were charged with to examine. And these were the facilitators and barriers to epilepsy medication adherence. And our age range was 0 to 16 years. But it's important to say that that was parents of children 0 to 16 years of age, but the children and young people who we interviewed were 5 to 16 years of age. Not to negate the value of the voice of that younger child, but of course their experience of and knowledge of their own medication adherence would be a lot more limited. We wanted to look at the barriers to epilepsy medication as perceived by these people and the potential changes that could be put in place. We're very aware that this was a small study, and so therefore we have not, some of what we say today will not necessarily be wholly transferable to other groups of people. But in essence, there was a lot of positive things that came out of this study, and we do feel that we can very much learn from the experiences of these families who were kind enough to participate in this work. So our data was gathered primarily by semi-structured interviews, but we also had a demographic questionnaire, which I'll come back to shortly. So our recruitment strategy was via charities, primarily Epilepsy Action and Young Epilepsy, and they were very, very helpful in disseminating flyers. For example, Young Epilepsy, they had a car fest in the bank holiday weekend in August, so they distributed flyers at that. Also, parents were very good at a snowballing effect, so we were able to sort of generate more interest from families via them posting, not just on the websites, but also with their contacts and so forth. We had a lot of people interested, but the number who actually came to fruition with interviews, as you can see, was a little bit lower. Because those charities are national, it did mean we had a reach across, I'll say the UK. In actual fact, all but one participant was based in England and the other one was in Scotland. But nevertheless, there was a reasonably good geographic spread. Before we actually went to ethics, we have a YPAG, a young people's advisory group at the University of Hertfordshire that's very well established. So we went to them for consultation about matters such as the documentation, but also we asked them for advice about writing up the report and also things about the gift vouchers that we gave to the young people who participated. And interestingly, they were absolutely adamant that whatever the age of the child or young person, they must all get exactly the same voucher amount. So a 7-year-old was not to get less than a 15-year-old, for example. So we followed their advice to the letter, of course. We wanted to recruit parents who had at least one child with epilepsy that had been diagnosed a minimum of 2 months. We felt that less than 2 months would mean that they had not gained that familiarity, obviously, with the medication and the importance of adhering to it. That medication should have been prescribed within the UK. Everybody was actually under NHS care, but if they had had a private prescription, they would have still been eligible to be included in the study. And they needed to be fluent in the English language. And the same applied to the children and young people. They were between 5 and 16 years of age, fulfilling that similar criteria. We also had a steering group which included staff from Health Innovation East. Richard was also on the steering group as a consultant paediatrician, and we had a clinical nurse specialist in epilepsy and a pharmacist, as well as other colleagues as well. That was really pivotal in them providing us with objective advice about each stage of the study. So we undertook, as you can see, 21 semi-structured interviews, 5 with children and young people and 16 with parents. So I'm just going to go on and tell you a little bit more about these before I share the findings. Because the families were living in quite diverse geographical areas, they were all interviewed using MS Teams. That seemed to work very well, and they were all digitally recorded, not just by Teams, but with a separate recorder as well, and carried out by 2 members of the team. Primarily, Sadia, my colleague, did most of them, but Rosemary did a couple as well. That then left me as somebody who was independent. I'd not participated in any of the interviews. So once they'd been transcribed by an independent agency, I was the one that analysed them with fresh eyes. I mentioned to you that there was a demographic pro forma. This was given to each of the 16 parents at the beginning of their interview. They could either fill it in themselves online, or we read it out to them and recorded their results. And this asked them for example, details of their occupancy, their postcode, because the postcode allowed us to assess them on the multiple scale of deprivation. I know the jury's out on how effective that is, but it gave us a rough idea of where people were living. It asked them for details of their children, how many they had, how many children had epilepsy, what medication they were on, when they were diagnosed, the age of diagnosis, and various other small bits of information such as that. So that was very useful for us to have to get the context for each family. The interview schedule was based upon the scope and review that has already been alluded to by Sophie, but also what was very helpful is we went back to the steering committee and they assessed all of our documentation and also including the interviews, and were able to give some really valuable and important feedback about that. So you can see that the questions and conversation focused on clearly the medication, the form that it came on, what works for the children and young people, and what they perceived were not only the barriers, but some of the changes that could potentially be put in place. So we had, as I said, 5 children and young people. This is, of course, a fairly small number, but as you know, it can be very difficult to recruit children and young people, and in particular boys. So although there was only 1 boy, that was good very much to have that male input. He was actually very chatty and full of conversation and really helpful. And you can see a brief breakdown of where these children and young people were living across the country, the type of medication they were on, and their ages. The diagnoses are being kept very loose here because we were advised by the ethics committee to do so because of obviously confidentiality reasons. There were, none of these children had special needs, although the parents who were interviewed had children with special needs, and obviously some of the children of the parents had multifaceted problems. So these children were all very articulate indeed. So there were 3 key themes that emerged from the children's interviews. As you might expect, these interviews were relatively short, particularly with the younger children because of their cognitive ability and their ability to be able to concentrate for any length of time. So the interviews lasted from, the shortest was 11 minutes up to 25 minutes. But nevertheless, they were able to give us some very interesting and very specific information. And conversation focused initially about everyday life and how their epilepsy impacted on that, their involvement in healthcare decisions, and then, of course, their epilepsy medication. And I'll say a little bit more about each of these on the next slide. But, you know, the importance of their medication came up, sometimes forgetting it, the reminder systems that use, and for some of them, the taste and format of the medication was not very pleasant indeed. So this was the young lad who said it tastes like rotten old eggs. So you probably know better than me which medication he's referring to. So it's just really a snapshot. The report is available online, and there's lots and lots of quotes in here from both the parents and children. So if you want to link to that, then obviously, Sophie, we can arrange that, can't we? So today is just really a little bit of a pray-save version. So suffice to say that children's knowledge of their epilepsy medication, how it works, and I think perhaps not unsurprisingly, was very limited indeed. But one thing they were very clear about in their minds was it was really important, and not one of them suggested that they would deliberately not take it. Having said that, it was quite clear that for some, in particular 9, 14, 15-year-olds that participated, that they were starting to get very embarrassed about their medication. So if, for example, they were at home with their family and medication was due in the evening, not a problem. They were with the people they knew and loved. They took the medication, you know, all being well. But when they were out with friends and they needed to take medication in the evening, perhaps they were at a party or something like that, they didn't want to take it in front of anybody. So this then became difficult. How do I navigate this situation so that I can get away a little bit from the group and actually take it? The biggest thing that impacted on the adherence was change, and this was very much reiterated by parents as well, change in the daily routine. So if it's a school week, you've got your system and your routine set up. But when you go on holiday or when you go out with friends, this is very different. So, for example, the 15-year-old participant was going on a Duke of Edinburgh trip. And this, as we know, one of the elements of it was a hike. And the teachers told her she was not able to take her epilepsy medication with her. They would have to hold it. So off she goes. There was a little bit of a battle that went on, but however, the teacher said no, they had to have it. Off she went on her hike. Time comes for medication. She's got none. So there was a right shenanigans to get the teachers to bring the medication. So she duly had it quite late, but did eventually take it. Suffice to say, next day of the hike, she was allowed to keep her medication because I think the poor teachers were run ragged trying to sort it out and getting very stressed as well. All of them reported a very substantive role from their parents in terms of epilepsy medication. Not altogether surprising, but even the older teenagers were saying things like, well, I don't worry too much because if I forget, Mum or Dad will remind me. So it was like a safety net for them. So that independence was slow to come, really. And I think we do need to think a little bit more about that because the parents reiterated that as well, that they were always keeping an eye on whether the medication being taken. And of course you would, because if your child doesn't take it, there could be consequences. There was some report of inconsistent involvement of children and young people in consultations. 2 of the children and young people reported that they felt that when they went for a hospital appointment, the focus was more on their parent who took them and asking them how they were doing. But then another 3 of them said quite the opposite, that they did feel very involved. So with such a small number, it's not, it's not easy to draw any conclusions from that. Very interestingly, though, all of these people were recruited via the charities. And so, therefore, all of the parents were very active in these charities. They'd been on the website or they had been on, various mechanisms supported by the charities. But the children and young people had no involvement with any of these groups at all. And one parent had said that her teenager had wanted to find out more information at a developmental level about epilepsy, but she didn't really, the mom didn't know really, where to direct her. So maybe that's a little bit food for thought as well. So I should say at this point as well that the children were all parents of those who were interviewed. There were no children who were interviewed without their parents supporting it. Some of the children were interviewed by themselves and some in the presence of their parents. So that's a very brief précis and snapshot of what the children and young people said. So we'll just move on to the parents. As I've said, there's a lot of illustrated quotes in the report. So just a little snapshot of this demographic questionnaire that I mentioned to you. The majority of parents were white, as you can see. All of them were mothers. So whilst there were some fathers that expressed an interest, they did not come to fruition. So I think that for further work is something we perhaps need to think about. All of these mothers were some were single, but they were all in relatively stable relationships with their partners. So whilst some mothers were living by themselves and had separated from their husband or partner, the partner was very supportive. So this data did not include also parents who were very much living on their own and had no support whatsoever. So I think that's another recommendation from this study to be looked at. The length of time for their child's epilepsy diagnosis to be confirmed was between 2 months and a year, but in actual fact, for most people, it was fairly quick, within 2 to 6 months. And the age of the children of these 16 parents was over 6 years. The majority of their children were diagnosed over 6 years, but you can see some were much younger. And some of the children had very, very complex, the children of these parents interviewed have very, very complex epilepsy and multiple diagnoses with complex special needs as well. So the interviews with the parents, not surprisingly, were much longer than with the children. And I think it was the first time that somebody had sat down and had a conversation with these mothers about what is it like for you. So I think some of them found it quite a cathartic experience, and they really saw it as such a positive thing just to talk. And of course, they therefore did not focus just on epilepsy medication, but they talked about their lives and how anxious they felt, how they gained information, not just about epilepsy, but also about the drugs that their children were prescribed, their involvement in healthcare decisions, the impact on everyday life, and of course, the medication regimes, where they got information from, the fear of running out of drugs, how they administered it. Sometimes it was easy, sometimes it was very difficult, the side effects of the medication, and also when they've forgotten to give a drug. Now I say when they forget to give a drug because every single parent talked about the times where they had accidentally forgotten to give the child medication. But there were only 2 parents that talked about giving more than the medication that had been prescribed. And one of these incidences was in a school environment, didn't involve a parent at all, and one was the parent themselves. Both the mother and father had given the drug, so the child was double dosed. But I don't think, talking to them, that they perceived giving more medication as non-adherence. Non-adherence seemed to centre around missing a dose or not giving enough of it. So these, once again, are just the headlines of some of the findings. So the things that parents talked about was this fear, panic, anxiety. They were totally on tenterhooks the whole time since their child had been diagnosed. I absolutely cannot emphasise enough what some of these parents went through. You know better than I do, but you know, the constant fear of running out of medication, the long-term effects of the medication. Will their child even get to adulthood? Some of these parents had to resuscitate their child post, respiratory arrest. So the whole time they felt they could not relax, and life was really hard, and they felt this emotional burden constantly. Having said that, they fought continually for their child to have a normal life. And, whether that was them being able to, go out with friends and family, swimming, climbing, whatever. But it was also a battle, and that sort of being vigilant the whole time. So there's two examples that come to mind. One is the 15-year-old girl that we interviewed. She was very interested in drama. So her mom had arranged to take her to a drama class every Saturday afternoon, which was for 2 hours. But the mother daren't go out of the car park for those 2 hours because this girl had had multiple convulsions, particularly round about the time of the interview. So she sat in the car park for 2 hours just in case anybody needed to contact her. So it's this sort of, being on call the whole time, which obviously is not just pertinent to epilepsy, but so many other illnesses that children and young people have. And on another occasion, one of the moms had a child with very, very complex needs, and the child was taken to school on a special school bus, and she wanted his medication to go with him because he was somebody that had convulsions, sometimes several times a day. And the bus refused to take the medication. The county council said no. So mother fought. Their argument was nobody on the bus can give the medication, therefore the child does not need it with him. Mom's view was no, nobody on the bus can give it, but when the ambulance comes, the paramedics can give it. And she felt that was a major battle, which she did win, and the child was allowed to take his medication. But there was this battleground the whole time going on. They felt they had to fight to get their opinion on everyday activities. I'm not talking about healthcare here, but everyday activities. Then there was this thirst for information and becoming an expert. And parents said they knew they should be going to the consultant or they should be going to the epilepsy nurse. But their fingers, they could not stop their fingers on the keyboard of Dr. Googling, as they called it, going onto charity websites, going onto Facebook. So a typical thing would be that the child's medication is changed. Where's the first port of call? Facebook Messenger. And starting an in-depth conversation with another parent whose child's been on this new medication, and they're backwards and forwards to the point of wearing themselves out. And they all said, but I know I should have just phoned somebody at the hospital. But it's that I've got to know I might be missing something. And as a result of this, there were two parents in particular who really took on board what they'd read on these various websites as, being the truth, and became, in their words, quite confrontational when they next went to see the consultant. So you just sort of feel sometimes that the healthcare practitioners were treading with one or two parents, quite a tricky balancing act. Their knowledge of medication, however, was, and non-adherence was quite limited, really. Their focus was very much on what's the best medication for the child and am I getting it? So they did not really get what non-adherence meant for them and their particular child. And, you know, if I miss a dose, do I give it later or do I? So one parent said, well, we missed a dose, so we just left it for 24 hours. And nothing happened. The child didn't have a convulsion, so it's fine. So there was this need, which I'll come on to, for this almost responsive advice. And this is something that I really pricked my ears up when Colin was talking about the epilepsy nurses, because some of the families had very, very good contact with epilepsy nurses. So they were on a WhatsApp group and they could just say, oh, my child's vomited. Might be nothing to do with epilepsy, they've just picked up a bug. My child's vomited, what do I do about giving the drugs? And they got an answer. Some people, they had epilepsy nurses, but they were only available 9 to 5, Monday to Friday, or they worked part-time hours. So that access was quite variable. Some of the consultants, 3 parents reported that 3 consultants had given their personal phone number to them just in case of an emergency. So gold star to those people. But what they did say was that actually, I've never used it. I don't want to use it. I want it as a safety net. That these were all 3 children had extremely complex epilepsy needs. But it was that, I know it's there just in case type of feeling. But the WhatsApp group for the epilepsy nurses, when that worked, that was fantastic because they got an answer straight away. They wanted involvement in decision-making with healthcare professionals, actually with the exception of 2 parents who I've already mentioned. They spoke so positively about healthcare support. They felt that, in particular, consultants were accessible. They talked to them about the titration of drugs up and down. Consultants said, I think we ought to change from this drug to another one. They felt very involved in those discussions. There were only 2 people that were involved, but they just hadn't happened to agree with what was being advised. So that part of it was really positive. It was then going back home and feeling a bit alone if things didn't go according to plan. So although these parents didn't understand the medication, they got the hang of all the titration and, you know, some quite complex procedures very, very quickly. Parents said that they took full responsibility for the adherence. So although they wanted to hand over responsibility because they knew that if they had a 14 or 15-year-old child, they may well be going to university in 2 or 3 years' time. So they had to, you know, be able to handle their own medication. But I suppose it was this fear, but if they forget and there could be consequences, you know, I'd blame myself. I'd never forgive myself if I didn't remind them. That's a bit of catch-22 because, of course, it's going to have implications if somebody does forget to take it. Very concerned about side effects, depending what medication the child was on. In particular, mood changes, putting on weight, long-term effects. That was the centre of a lot of Googling and talking to a lot of other parents. And I think one of the things that these parents are crying out for is being directed to really good resources. So one parent commented that a paediatrician had directed her to the children's medicine site, and she said, you know, that was just so wonderful that they seem to report. So I don't know whether it's their perception of not taking in all of the information when they're in a consultation, but they seem to need clear signposting to where they can get information when they walk out of that consulting room. And a range of strategies were used as reminders, and this included diaries, each other, putting the medication by the front door, various alarm systems, but the one that stood out more than anything that most of them went back to or actually went out and purchased was a Dosset box, because they said it was just fit for purpose, and actually, you know, you couldn't rely on your husband to say, yes, I'd given it, not I'd given it. People were forgetting, they've got busy lives, but I can see no tablets in that little slot child either had or not had. So our recommendations, definitely parents are crying out to get responsive advice. So they're not looking for somebody to be at the end of a phone 24/7. They're looking for, if something goes wrong, I can't rely on ringing 111 and getting a bespoke answer to my individual child. Being able to WhatsApp an epilepsy nurse and get a bit of advice would be great. And this might be once, only every few weeks, but it's who do I go to? Building trust was really important. So for a couple of parents, their consultant had changed. So that meant we've got to start again on this journey, building trust with somebody else. And that took a little bit of time, understandably. Most successful reminder, I've said, was the Dosset box. One of the things that, and we do think that actually this was something that parents went out and purchased, but this is something that we could think a lot more about because it's so cheap and accessible. Is that something that could be supplied? There's definitely a lack of understanding about adherence and what it specifically means for each individual child. So maybe always asking to every consultation about adherence, what have you taken, any problems, have you given too much, have you managed to stick to the times, etc., etc. And then being directed to clear, good quality resources is really important. So, final slide, that we do feel that we've, a good stepping stone here for future work. And that it has revealed some really interesting things. We can learn so much from these parents who are working so hard to support their children and young people with epilepsy and are doing, on the whole, the most fantastic job. And the insight from the children and young people themselves was phenomenal. But we do need to think a little bit more about a different population, in particular single parents who might be struggling and not have good financial backing. I have to say that in this group, their socioeconomic status varied from 1 to 10, so there was a good breadth of it. But as I say, they were in fairly stable relationships, and that makes a lot of difference. It would be good to get some perspectives of fathers, and of course, more views from children and young people, in particular people from different ethnic diversities and more boys. And I think thinking about how this links to an international context would be good because, what are the same problems as are being faced internationally as well. So I say, really the starting point, but it was a total privilege to be involved in this study. The families were just fantastic and wonderful that they gave up their time. So thank you, and I'll hand over to Sophie.
Thanks, Lisa. So I'm aware of time, so I'll try to go through this relatively quickly. But I mentioned that once the evidence review and the consultation were complete, we adopted a biodesign approach to try to understand the needs that were coming out of that. And this diagram tries to show what that approach is. It's something that's been developed by Stanford University in the States, and it's increasingly being used to basically pull together what's already happening with technology and user need, and narrow those needs down to basically create a concept. And it's increasingly being used to actually develop technology, so not necessarily to have a look at what's already out there, which is what we did. But the idea being that you have a very long list of needs, you narrow them down, and then you can create kind of your must-haves and your nice-to-haves for the final concept of what you might develop. And I mentioned that the whole process really is based on the idea of being solution agnostic. So the idea that you're purely starting from the need rather than anything that's already out there as a solution. So a need statement is composed in that way that's outlined at the top of the slide. So a way to address the problem in a specific population in order to achieve a desired outcome. And it can be really easy when developing a need statement to kind of build in a solution. It's harder than it's harder than it looks to be solution agnostic. So that's demonstrated by the pictures we've got here. You might think that you need a way to cut the grass. Immediately there, you're jumping to a solution of cutting the grass, when actually the solution agnostic need, is a way to keep the grass short. There might be other ways that you could do that, illustrated here by a goat. So the idea is that you're completely solution agnostic at this stage, and you're just trying to focus on what the need might be. So what we did was we took the evidence review and the results that had come out of the consultation that Lisa's just presented, and developed a list of draft need statements that we then worked on with the steering group as in an interactive workshop to try and refine these and improve them, and also select a couple that we were going to do deep dives on and focus on in a little bit more detail. So as you can see on the left-hand side, we tried to categorize these into sort of general areas. So some were related to, for example, parent-carer anxiety, which we've just heard quite a lot around, parent-carer resourcefulness and involvement. There were logistical things around actually acquiring the medication and administering the medication. A few things came up around side effects and forgetfulness. So we tried to develop the draft need statements that would collate together what we think the actual need related to these themes are. So, for example, top, a way to reduce parent/carer anxiety for parents of children with epilepsy in order to improve quality of life and medication adherence. Because we heard that the parent-carer anxiety and the level of anxiety was really impacting on quality of life in a number of cases, and could impact on the actual quality of adherence as well. So after that interactive workshop with the steering group, as I say, we kind of refined those need statements through a series of interactive activities. And then we selected two to focus on in a bit more detail. And these were the two that we focused on the left there. So a way to help children and young people and their families to remember all medication doses in order to support medication adherence. We heard that forgetfulness was really significant, and as Lisa said, particularly when there was a change in routines or when things was a little bit different for the family, it was very easy for medication just to be missed purely through forgetfulness. And then also, as Lisa said, it was really highlighted the need for information and trusted information and resources. So the second one we focused on was a way to address unmet information needs for children and young people and their families in order to provide tailored and responsive advice to support medication adherence. And when developing the Horizon scan request in terms of looking for innovations that might address those needs, we also developed must-have and nice-to-have criteria as part of this interactive workshop. So I won't run through all of those, but for example, you can see that it was things like the service available across all geographies, tailored to all families, from a literacy and language perspective, for example, to be cost neutral or better. And when we're talking about advice and access to information, something that's available 7 days a week, something that's timely and that's going to enable a timely response from clinicians and a rapid response to very urgent requests. Again, health inequalities considerations, etc. So these were the criteria that we used to actually scan new and emerging innovations that might be able to address these needs. And there's a lot on this slide, but this is just to demonstrate a little bit more about that Horizon scan process and what came out of that. So this is the one around remembering all medication doses, and the table at the top just outlines the criteria that was met by these particular innovations. And we did deep dives on a digital health passport, which is an innovation that's been developed by Tiny Medical App, originally for asthma and is in the process of being developed for epilepsy, and an app called HEBA Child Health Tracker. So I'll talk about the digital health passport in a little bit more detail, but just to say that for both of those needs statements that we identified, those two innovations were actually applicable to both of them. And so they're why we particularly chose to do deep dive case studies on those. So just to tell you a little bit about the digital health passport that's been developed by Technical Medical Apps, it's really a platform to support self-management and patient activation. So it's been developed for asthma, and it's much more advanced for asthma, and it's been evaluated for children with asthma and with very promising results. And now Tiny Medical Apps have received additional funding from SBRI to develop this for children with epilepsy. And so this is only just being developed. That funding was granted in February this year, but it's building on the digital health platform that already exists for asthma. So there's a lot of work that's already been done, and there's a lot of plans as to how this can be effective. So essentially, it allows effective self-management. So it has medication reminders. It provides information and trusted advice and guidance to help children and young people better understand their condition, and also how the medication that they're taking works and relates to their condition. It also allows seizure tracking. There's plans to enable seizure tracking for the epilepsy app. And in the asthma case, it allows quite granular symptom tracking that's paired with environmental data around pollution and how good the air quality is. There's plans for it to be connected with healthcare professionals so that healthcare professionals can communicate directly through it, and it can serve as that two-way communication. And so there's plans for it to be integrated with NHS systems, although that's in the process of being developed. And this has been co-developed by or with a diverse group of children and young people and their families. So there's a lot already there that can be built upon. And this is just a snapshot of sort of the kind of information that would be provided about the medication, that you can kind of set up reminders, that you can click through and understand a little bit more about what that medication is, why you would take it, how you take it, etc. And just enable basically that patient empowerment and activation to better understand condition and how the medications are working. This is just a snapshot of evidence that's already out there. So as I've said, it's already built on that existing platform. It's aimed at children and young people who are aged 13 to 25, living with epilepsy, including for mild to moderate learning disabilities, which is a conscious decision that's been taken by the developers of the tool. At the moment, this is really only just being developed for epilepsy, as I've said, but it's a lot more developed for asthma. So the return on investment for the asthma app, not the epilepsy one, was £9.78 for every £1 spent over a 3-year period. And largely that's based on improved asthma control and reduced admissions and healthcare contacts through improved self-management. But a lot of assumptions were made as part of that modelling, and you can see that through an evaluation report that's been put together by UCL partners on that asthma app. As I say, this is in the process of development through SBRI funding, and is being kind of developed and tested this year for epilepsy, but shows how timely this work is really, and that this is only just coming to the fore and will be ready for piloting relatively soon. So just to say that this is, we've got 3 publications from this work at the moment, with more upcoming. So there's a whole report that's just on the evidence review that's on the Health Innovation East website, and that goes into a lot of detail about what came out from the evidence, the published evidence. There's also a whole report on the consultation that Lisa's already mentioned, and obviously there's lots of detail in there and lots of quotes, as Lisa's already said, on what children, young people and their families said. And then there's also a summary report that pulls all of that together, including more information about the biodesign process, how we develop those needs statements, how we then scanned for emerging innovations, and then we've done deep dive case studies on those innovations as well, including that Digital Health Passport one that I've just mentioned. So that was it. There's a lot more to have a look at if you're interested, but we do also have some questions as well, I believe, on Mentimeter.
We do indeed. Yes. So, yeah, I'm sorry that we've run slightly over. I'm just going to keep you for 2 seconds whilst we use your expertise. So I'm just going to present this. So if you could kindly all go to Menti and use the code that's on the screen here. So I shall read it out twice: 39359575. Then I shall just give the customary 4 seconds break just for everybody to get their phones out, type in Menti, and then I'll read it again. 39359575. Be incredibly grateful for everybody that's watching remotely. Just to put your thoughts into this first quite open question: how has today's discussion resonated with you? So while you're thinking about that, I'll just mention our plans. So we've run over a little bit into our break, and we're going to trim that time off my presentation shortly after the break, which will be no problem. So you will be away on time, I promise. We will draw the whole conference to a conclusion on time. Okay, so the Menti code is 39359575. So that there's no QR code if you're looking for a QR code. There is only, so if you go to menti.com and put in the code 39359575. What's the thing about ducks and 22? Can't remember. 2 ducks, maybe. Pair of ducks. Anybody know what I'm talking about? Bingo. No? Yeah. No. Okay. 2 little ducks. There you go. Pair of ducks. Same thing. Right. Thank you. So next question. Same code. Considering the effort required for practical implementation, which areas do you think should be prioritized in terms of how we can help with medication adherence? Really grateful for your thoughts on this, because this will fuel the next aspect of our project. And I'd like you to have a think. So we use the term climate here, but of course what we're proposing here at the conference is climate change. What solutions can you effectively resource given the current climate? And I think by current climate, what we're saying is that nothing's falling off the money tree at the moment. Yes, I probably haven't explained that very well, have I? Yes. So we appreciate that every time anybody is asked to do something new, or any time that there is a change in how we describe quality and ask you to do something extra, then the question was always, but how do we fit that into our time schedule? We don't have any spare time. How can we do something better? How can we do something more? What could you do given the current climate? And I think I'm going to leave that last question because that is part of the question before. So I'd like to extend my thanks again to Lisa Whiting and Sophie Knight. Thank you very much for a fantastic presentation. And we will take forward the issue of medication adherence within Open UK and try to deliver something nationally that is helpful. So we are now proceeding into the break. So shall we say come back at 35? Yeah, 15:35. There we go. So it's a 12-minute break. Thank you very much. See you then.